Hello, I'm Michael Orangias, one of the pediatric pulmonology and sleep specialists here at U of L and Norton Children's. I don't have any financial disclosures or conflict of interest, and I was going to talk a little bit about sleep disorders and development, specifically sleep disorder breathing and sleep apnea. So there's an ever-growing body of evidence suggesting that sleep disorders may interfere with physical, cognitive, emotional, and social development, and gas exchange abnormalities and multiple arousals associated with sleep apnea can lead to significant morbidity in pediatrics. And it's important to note that children with sleep disorders may present with different symptoms than do adults. And within the pediatric age groups, the manifestations of sleep apnea may vary by age and developmental level. So I'm sure everybody or most people know what sleep apnea is, but the strict definition is repeated episodes of prolonged upper airway obstruction despite continued or increased respiratory effort. This results in complete or partial cessation of airflow through the nose and or mouth, and it may or may not lead to gas exchange abnormalities leading to hypoxia or hypoventilation. But respiratory disturbances can lead to arousals and sleep fragmentation. And, sleep apnea is important to screen for because it can result in hemodynamic, autonomic, inflammatory, and metabolic effects. And, it can present itself with a variety of morbidity. So sleep disordered breathing refers to a clinical spectrum of disease, with sleep apnea being on one end of that spectrum and snoring on the other. But snoring is typically the most common feature of sleep disordered breathing regardless. So snoring without obstructive apnea can still result in frequent arousals from sleep and gas exchange abnormalities. And habitual snoring is indicative of increased upper airway resistance. It may be associated with adverse neural developmental outcomes in children. In between snoring and sleep apnea, you have something called upper airway resistance syndrome. That typically occurs with airflow limitation. It can induce arousals from sleep, although it may be more subtle than sleep apnea. It's more common in thin individuals and those with specific craniofacial abnormalities. And I don't want to get too far in the weeds with this, but you can still have sleep fragmentation with upper airway resistance, but it may be more discrete. So the sleep study may be read as normal or mild sleep apnea requiring no treatment. That's in part because there's not really a consensus on the optimal detection or management or the degree of clinical impact, but it can be significant in the right context. So moving on to epidemiology, snoring occurs in about 11% of those children aged 1 to 9, but the prevalence of habitual snoring varies widely depending on the source and definition. It's estimated about 3 to 12% of children have primary snoring. Sleep apnea is most common between the ages of 2 to 6. Some sources say 2 to 8, but it can really occur anytime throughout childhood. It's about equal in boys and girls, although it may be a little bit more prevalent in boys. But after puberty, it becomes more common in boys overall. And then depending on the threshold to diagnose sleep apnea, the prevalence in pediatric OSA occurs in about 1 to 5% of children. As I'm sure most of us know, adenotonsillar hypertrophy and obesity are the most common risk factors in otherwise healthy children, but the prevalence may range from 13 to 59% in obesity. It also varies, the presence of sleep apnea also varies by race. It's more prevalent in African Americans who are younger than 35 compared to Caucasians of the same age group, independent of body weight. And it's also the prevalence of sleep apnea is similar in Asia as it is to the United States, despite lower rates of obesity. There are various mechanisms. Some of these are the more common ones, but you can see just decreased upper airway patency. You get narrowed pharyngeal airways, increased nasal resistance, increased upper airway collapsibility. The pharyngeal dilator activity is decreased in REM sleep. You can have decreased respiratory drive and an increased arousal threshold, and that increased arousal threshold can lead to reduced perception of upper airway occlusion. As we've already kind of talked about and discussed, adenotonsillar hypertrophy is one of the most common risk factors in children. Adenoids are best visualized by nasal endoscopy, and they can contribute to reduction in the airway size. Adenoids are actively growing between the ages of 2 to 6 and begin to decrease in size after about 10 years of age, while tonsils are generally more actively developing between ages 2 to 5. Under normal conditions, they gradually atrophy and disappear by the ages of 14 to 15. And that's in the majority of the people. But in pathological hypertrophy of the adenoids and tonsils, they may be unable to atrophy normally. With obesity, you get increased fatty infiltration of the upper airway, increased neck size, more weight on the chest wall and abdomen, decreased diaphragmatic excursion, reduced intrathoracic volume, and then thus you may need less adenotonsillar tissue to cause obstruction compared to those who aren't obese. GERD can result in pharyngeal edema, which can contribute. Neuromuscular disease is an obvious risk factor with decreased upper airway tone. And then hypothyroidism may be due to reduced upper airway patency and reduced central respiratory drive. So children with congenital syndromes, cranial facial abnormalities like retrognathia, micrognathia, mid-face hypoplasia are at higher risk, and those with neuromuscular disease than those without. And then, up to 85% of children with PRO band sequence can have sleep disorder breathing. Isolated cleft palate probably isn't a risk factor in and of itself, but it's usually associated with other conditions that may contribute. Orthodontic problems, high narrow palate, overlapping incisors, frostbite, and then chronic nasal obstruction and mouth breathing, especially within the first 4 years, because that can lead to impairments in maxillary mandibular growth and increase the risk of sleep disorder breathing. There are pulmonary causes like laryngeal malacia, tracheal malacia, and subglottic stenosis. And Down syndrome is a big one. You get glossoptosis, macroglossia, obesity, mid-face hypoplasia, and commonly hypothyroidism. And the estimated prevalence of sleep apnea in children with Down syndrome is 30 to 100%. And then all children with Down syndrome should have a sleep study by the time they're 4 years old. Over 50% of children with achondroplasia can be at risk for sleep disorder breathing, mucopolysaccharidosis like Hunter syndrome, Hurler syndrome, history of prematurity and multiple gestations. Marfan's is one that we might not commonly think of as much, but you can have head and facial abnormalities like a high arch palate and retrognathia, airway malacia. And then, sleep disorder breathing with Marfan's can expose them to highly negative intrathoracic pressures. And those pressure swings can increase aortic transmural pressure and accelerate aortic dilatation. And then children and adolescents with sickle cell are also at higher risk. They have reduced upper airway diameters and increased adenoid and tonsil size compared to other children. And if sleep apnea is present, nocturnal hypoxemia can lead to more complications than in sickle cell patients without obstructive sleep apnea. Basically, any condition with neurologic, skeletal, or dental conditions that reduce upper airway size or affect neural control of breathing or impact collapsibility of the airway can contribute to sleep apnea. And then individuals presenting with sleep apnea in infancy are higher likelihood of having underlying anatomic or genetic causes, so that's important to investigate. And then other risk factors that can contribute are environmental smoke exposure, asthma, allergic rhinitis, and then some studies suggest severe lower respiratory tract infection in infancy and subsequent increased risk for sleep disorder breathing. Prader-Willi syndrome patients are notorious for being at higher risk for sleep disorder breathing due to obesity, hypotonia, scoliosis, hypoventilation. Growth hormone therapy is commonly used because it can improve lung function, it can improve linear growth, body composition, but it can also trigger or worsen hypoventilation. And long-term growth hormone therapy can contribute to adenotonsillar hypertrophy. So it's important to balance, improving, long-term outcomes or worsening serious sleep disorder breathing. So you typically get a polysomnogram before and after initiation of growth hormone. So I'm sure, people screen for sleep apnea all the time in clinic, but some important features to note are habitual or loud snoring, especially greater than or equal to 3 days a week. Other nocturnal symptoms may just be noisy breathing, pauses in breathing, coughing, choking in sleep, restless sleep, nighttime sweating, bruxism, mouth breathing. And then morning headaches can be a common presenting symptom due to disrupted sleep, increased arousals, low oxygen. And it's important to note though that sleep disorder breathing in infants may be more subtle, and they may just present simply with noisy breathing, sweating with sleep, or sleep disturbances and restless sleep. Again, important to mention that they don't present like adults, children with obstructive sleep apnea per se. Sometimes they do, but typically not. Although adolescents may similarly present with excessive daytime sleepiness. If they're driving, that can increase the risk of accidents. Oops, excuse me. But daytime sleepiness may be less obvious in younger children. It may manifest as age-inappropriate napping, complaints of sleepiness, falling asleep on the bus, falling asleep on the car ride home, etc. And then younger children may paradoxically present with poor cognition, inattention, hyperactivity, depression, mood lability, and may be diagnosed with ADHD. Some children will complain of dysphagia due to tonsil hypertrophy, chronic nasal congestion, frequent otitis, sinusitis, hyponasal speech from adenoid growth, and then sometimes with somatic symptoms, including social withdrawal. Other associations, we obviously know obesity, but failure to thrive can be noted due to increased metabolic demands during sleep, energy use, alterations in growth hormone secretion, and even from a decreased appetite, increased seizure risk, so a lower seizure threshold due to arousal increases in hypoxemia. And then you can see nocturia postulated some association with lower oxygen levels and increased cardiac production of atrial natriuretic peptide. You may see potential overlap or exacerbation of other sleep issues like non-REM parasomnia, such as sleepwalking, confusional arousals, night terrors. Children with sleep disorder breathing or increased risk of sleep fragmentation. So if your sleep disorder breathing is triggering an arousal out of slow wave sleep, then that can exacerbate these non-REM parasomnias. And then children with sleep disorder breathing may have compensatory increases in slow wave sleep, which you typically see in arousal from awakeness out of slow wave sleep when you see these parasomnias. And then, it may increase other comorbid sleep issues like frequency of restless leg symptoms, nocturnal awakenings, and even bedtime resistance in younger children. So in addition to the neurocognitive sequela, there are potential cardiovascular and metabolic issues as well. So you can see systemic inflammation, alterations in autonomic regulation, vascular endothelial changes, metabolic dysregulation. Some studies have shown associations with sleep disorder breathing, the above listed metabolic sequelae like lipid homeostasis alteration, insulin resistance. This is more likely important in older children, especially those with obesity. And then obesity with concomitant sleep apnea also puts you at increased risk for non-alcoholic steatohepatitis or NASH. And then so it's important to systematically screen obese and overweight children for sleep disorder breathing. And then you can see cardiovascular sequela, so increased right ventricular and left ventricular strain, systemic hypertension. In adults, sleep apnea is associated with pulmonary hypertension, albeit it's typically mild unless they have other comorbid issues like COPD or obesity hypoventilation syndrome. But you can see elevated pulmonary arterial pressures in the setting of sleep disorder breathing in children, and treatment of sleep apnea can effectively reverse that pulmonary hypertension. So, these processes lead to endothelial dysfunction in children with sleep apnea, but they haven't really been fully elucidated, the mechanisms. However, it's postulated there's upregulation of the systemic inflammatory responses and oxidative stress, and those are thought to underlie the progression of disease, such as discussed in the paper there above on the top left of your screen. So, big red flags we've already talked about with snoring regularly. But it's important to directly screen, because parents may not think that snoring is important. Some parents even think it's kind of comical, and they may not be aware of the links between behavioral concerns and sleep apnea. So I'm not going to go through all this in detail, but there's various questionnaires in adults through the stop bang criteria. There are some screening tools in children, like this one, which is called the BEARS screen test, and it can evaluate for sleep problems in different domains in children between 2 and 18 years old. We've already mentioned obesity and failure to thrive, so it's important to look at the growth curves. A good oral and ear, nose, and throat exam is important. Here are the criteria for Mallampati and tonsillar grading. 0, tonsils not present, 4+, tonsils are crossing the midline. And then on the right of the screen, the Mallampati scoring. Class 1, as you can see, complete visualization of the soft palate, and class 4, you can't see the soft palate at all. And then, although the tonsils may be large and contribute to a reduction in airway size, there's no clear linear correlation between size of tonsils and the greater severity of sleep apnea. So it's important to note that small tonsils may be clinically significant and cause obstruction during sleep, especially in overweight or obese children. You want to evaluate for signs of allergies, high arched palate, retrusive chin, retrognathia, micrognathia, like we talked about. Sometimes providers will get an upright lateral neck film to look for tonsillar adenoid hypertrophy, adenoidal regrowth, or lingual tonsils. But it's important to note that no matter what screening you're doing or evaluation, you cannot distinguish between primary snoring and sleep apnea without a sleep study. So if a child has never had a sleep study, they cannot be diagnosed with sleep apnea. So this is a busy slide. Again, I'm not going to go through everything, but just want to kind of introduce a few terms and show that sleep disorder breathing is on a spectrum. Apneas are greater than 90% decrease in airflow. Hypopnea is 30% or more with concomitant desaturation in oxygen or an arousal. We have various thresholds to diagnose hypoxemia with an oxygen nadir, typically 90%. And then, with a percent of time spent below 90%, typically 5 minutes or more. And then hypercapnia as well. We use end-tidal and/or transcutaneous monitoring in pediatric studies. It's routine. In adults, it's not routinely used, so you have to request it. And then, the AHI, which is, kind of the defining feature of what you see reported in a sleep study, consists of apneas, hypopneas, and central events, but the obstructive apnea-hypopnea index is only the obstructive apneas, obstructive hypopneas, and the mixed apneas. So the apnea-hypopnea index, or the AHI, is the number of apneas plus hypopneas which occur per hour of sleep. There's no universal agreement about the cutoff AHI in pediatrics, but typically it's agreed upon that 1 or more in the presence of clinically significant signs is defined as sleep apnea. Or you can also diagnose sleep apnea in pediatrics with evidence of hypoventilation, even with a lower AHI. And the definition for that is a carbon dioxide level of greater than 50 millimeters of mercury or more for more than 25% of the sleep time. But so, kind of when going back to the AHI is typically what you see reported, but it's important to consider the oxygen nadir, hypoxemia, signs of hypoventilation. The AHI doesn't tell you how low the oxygen levels get. It doesn't measure how long an apnea event happens, and it may vary from night to night or with sleeping position. So it's really just a long-winded way of me saying that, the AHI alone may not always sync with symptoms or outcomes and severity values. So, the severity values are based on, expert opinion and a limited consensus, but they're not evidence-based. So, it's important to take all of this into context other than just that one number. And then with, there are the severity grading for adult and pediatric sleep apnea, but you can interpret a sleep study in a pediatric patient or an adolescent age 13 or older with pediatric scoring rules and criteria, or adult. Typically, adolescents are scored with adult rules unless they have other reasons like significant comorbidities, neuromuscular weakness, genetic reasons and things like that too. But it is up to the discretion of the provider. And it's also important to note that there's no normative value for infants. So here's an overview of the leads used on a polysomnogram. Look at EEG leads, eye leads, airflow devices, chin tone, cardiac lead with ECG, pulse oximetry monitoring, leg movements, and then thoracic and abdominal belts. So you can imagine having all this equipment hooked up to you would be difficult for anybody to sleep, more or less a child, especially one with significant comorbidities or neurodevelopmental issues. And it can be very stressful and inconvenient for the parents. And some children may need multiple studies. And here is just, you can see how the signals translate onto the polysomnogram. Again, I'm not going to go through all this in detail, but the leads may be aligned different depending on the provider's preference. But you can see the outlined events there with cessation of airflow, indicating an obstructive event. And if you look a couple leads up, you can see the chest and abdomen, there's still effort. So with still having effort and the cessation of airflow, that would be described as a obstructive event. If there was no effort in the other belts, then that would be a central event with cessation of airflow. So the polysomnogram, again, is essential for distinguishing between primary snoring and sleep apnea. It's important to assess how treatment interventions such as CPAP or post-adenoid tonsillectomy, it can be used to delineate the severity of sleep apnea. So some may be wondering about the home sleep apnea test. These are acceptable options for adults, although they have been approved for adolescents 13 and above by the FDA. They're not routinely recommended. There's a statement paper with the American Academy of Sleep Medicine on that. And the main concern is, one, you don't get as many data points. And two, there's a lot of room for error, especially in younger children, because they can pull something off. And, if you're not in a controlled environment, then it can't be replaced, like if you're in the sleep lab. So pictured here on the bottom is called a watchpad. It uses peripheral arterial tonometry, and it measures peripheral arterial vascular tone using plasmographic methods. And there are other things that can interfere with testing as well, using the arterial tone, certain medications like alpha blockers, or patients with cardiac arrhythmias, especially AFib. Not typically as likely in pediatrics, but it's worth noting. And then the other screening tool at the top there is an overnight pulse oximetry. I use these pretty routinely, especially on the pulmonary side. One, if I'm worried about nocturnal hypoxemia, or two, if I'm waiting for a sleep study. And it uses a plasmographic method as well and looks at heart rate variability, but it's subjective to an incredible amount of artifact, and it can't distinguish between events if they're apneic events or other. And then, I don't want to get too far off subject, but it's important to note that polysomnogram, again, can differentiate between central and obstructive sleep apnea. Here you can see risk factors for central sleep apnea. The top picture on the right there, you can see a QRM malformation, and with those you can see compression of the brainstem affecting respiratory centers and affecting your respiratory drive, leading to sleep apnea. And then again, these are some other less common, but some children you may follow in clinic with central hypoventilation syndromes, congenital central hypoventilation syndrome, or CCHS, and ROHAD. These conditions present with sleep apnea, but they also have systemic other manifestations as well. So I'll kind of leave those for now. So getting into treatment, it may be straightforward. It may not be. For example, children with mild sleep apnea, they may fail to demonstrate severe findings on polysomnogram. And you need to correlate that with behavioral and other comorbidities as well. So you can see neurobehavioral deficits even with primary snoring. So, basically the OSA threshold and consequences vary widely with different individuals. So it's relatively more straightforward for moderate or severe sleep apnea, especially if there's adenotonsillar hypertrophy. Would recommend a tonsillectomy and adenoidectomy. But, there can be significant complications. That's not a benign procedure, especially children with severe sleep apnea or children younger than 3, failure to thrive, obesity, craniofacial abnormalities, neuromuscular disorders. So if these children are going for intervention, it's important to watch them closely, and they're usually monitored in the ICU after their procedure is done. There are other non-surgical treatments like watchful waiting and medication, CPAP, positional therapy, which I'll briefly talk about a couple. This is a study done in children 5 to 9 who were followed with watchful waiting. It's otherwise known as the childhood adenotonsillectomy trial or the CHAT trial. And there's a similar trial on the right there, age 2 to 4, studied in a similar manner. And basically, it looked at otherwise healthy children with mild or moderate sleep apnea with PSG confirmed AHI greater than 1 or less than 10, who did not have significant hypoxemia or hypoventilation. And they looked at doing adenotonsillectomy versus watchful waiting for up to 6 months with supportive care. And they determined that's reasonable. In the CHAT trial compared to watchful waiting, surgical intervention did not significantly improve attention or executive function. However, it did lead to improvement in behaviors, sleep apnea symptoms, subjective sleepiness, and quality of life. Supportive care may be reasonable in the right context, and that may consist of treatment of or referral for treatment of comorbidities like asthma, allergic rhinitis, education regarding sleep hygiene, sleep practices, weight management, use of nasal steroids or nasal sprays and or montelukast. And then these studies do provide evidence that adenotonsillectomy may be beneficial, but it's also appropriate to wait in the appropriate setting. However, if you are electing for watchful waiting, it's important to have reevaluation within 6 months or sooner if symptoms are worsening or other concerns arise. This was a randomized trial published in late 2023. It looked at about 460 children who were aged 3 to almost 13 with snoring and an AHI of less than 3. And it was done at 7 U.S. academic centers, and patients were followed for 12 months. And then participants were randomized 1-to-1 for adenotonsillectomy or watchful waiting. And the primary outcomes were similar to the CHAT trial. So in children with sleep disorder breathing, adenotonsillectomy, when compared to watchful waiting, didn't improve executive function or attention at 12 months. However, children that underwent the surgical intervention did have improved secondary outcomes, including behavioral symptoms, quality of life, and decreased blood pressure. So this was a recently published ATS guideline. It looked at persistent sleep apnea despite a tonsillectomy adenoidectomy. And so the authors defined persistent sleep apnea as an obstructive AHI greater than 1. But the recommendations were focused on obstructive AHIs greater than 5, just because there's limited available data on guidance for treatment and management options. And there's a higher risk for neurocognitive sequelae in these children with OHI of greater than 5. So recommendations, basically summary, were noted as favoring CPAP if patients were not otherwise candidates for site-specific upper airway treatment, orthodontic or dental facial orthopedic treatment, like certain craniofacial features, weight loss interventions, if they were not candidates for lingual tonsillectomy or supraglottoplasty in those with laryngomalacia. And then they also recommended considering montelukast if already on intranasal steroids. So in summary, otherwise healthy children with mild or moderate sleep apnea. So again, AHI greater than 1 or less than 10 is confirmed with PSG. Watchful waiting with supportive care is reasonable. With severe sleep apnea, we typically recommend tonsillectomy, adenoidectomy, and appropriate candidates. But afterwards, it's important to follow up. And then especially if it's with severe sleep apnea, you do want to repeat a sleep study to make sure that the intervention was successful. And then CPAP therapy may still be appropriate with an AHI greater than 1 if there's minimal tonsillar tissue or persistent symptoms of sleep apnea after surgery, or a strong preference for no surgery. So CPAP is very effective, but it's not without complication or risk either. And, potential complications are eye irritation, skin ulceration, conjunctivitis, skin discoloration, discomfort, irritation. But these symptoms can be, mitigated or minimized by proper mask fitting and refitting of the mask as they get older. And so it's important to fit the mask tight, but not too tight. So tight enough to prevent air leaks, but you also don't want excessive pressure, especially in young children, because that can alter facial or dental structure development as they grow. You can see nasal complaints. A lot of times that can be congestion or rhinorrhea. You can use nasal sprays or nasal steroids to help. Some patients complain of aerophagia, so they're swallowing, air throughout the night and results in belching, burping, passing gas. Sometimes different positions can help with that. And then you can also utilize rapid maxillary or mandibular expansion, or RME, and that's considered for children with OSA who have a narrow palate, who have little adenotonsillar tissue, or those in residual OSA after TNA. But it can only be used prior to midline fusion of the maxilla, which generally occurs shortly before puberty. And just a brief note that children with Down syndrome are obviously very high risk for sleep disorder breathing, and adherence and tolerance can really be an issue in these patient populations. The hypoglossal nerve stimulator, which is used, was approved for adults a couple of years ago, has recently been approved in 2023 for trisomy patients 13 and above. They had to fit certain criteria, which I'm not going to go into all the details of that, but they also they can't be amenable to another intervention, such as they, can't be a candidate for tonsil adenoidectomy or, or other interventions. So it's kind of a last-ditch effort. And basically, there are three leads, implantable components. It does require a minor surgery and, and tolerance, building up tolerance, but it, results in tongue protrusion and upper airway dilation, and that can help with the obstructive events. But any patient that's being considered for this must first undergo a DICE, or a drug-induced sleep endoscopy with ENT, to assess airway pattern collapses, because certain patterns of collapsibility are not candidates for this intervention. So figuring out barriers is important, noting that, that can reduce adherence or compliance, whatever you want to call it. There can be a sense of claustrophobia, and desensitization can work with kids. It can take a lot of patience and reassurance. Some desensitization techniques, you can have the patient wear their mask while they're away, work with occupational therapy, watch other kids wear it. I have some kids, if they have like a favorite toy or doll, put it on their favorite toy and doll so they can make that association, and that can be helpful. So basically, early intervention and close follow-up are key in sleep apnea. And it's important to note that early recognition can lead to better outcomes. Pediatric sleep apnea can have significant consequences. Treatment plans are not always straightforward, and it is important to individualize treatment and have a longitudinal follow-up. These are my references, and I thank you for allowing me to participate. Thanks.